Hi, I'm Allison Barley. I'm going to be a senior at Avon High School this fall. This summer I was in the orthopedic surgery department at Lutheran Hospital, and my project is on the patient-perceived quality of life impact following total shoulder arthroplasty. Some reasons to have a shoulder replacement could be osteoarthritis, trauma to the shoulder area, rheumatoid arthritis, rotator cuff tear arthropathy, which can be contained or non-contained. And rotator cuff tear arthropathy is a combination of arthritis and a mild rotator cuff tear, and avascular necrosis, which is when there's not enough blood to the bones, causing it to die, and then a failed previous surgery. In the surgical consultation, certain things such as diabetes and smoking can cause the patient to heal slower, so the surgeon needs to go over that with the patient, and then the surgeon will also look at the x-rays and do a physical exam to see how the affected joint can function. This is the thought process used to decide what type of implant to use. And the types of implants are a standard total shoulder arthroplasty, a reverse total shoulder arthroplasty, a cup arthroplasty, or a revision, which can be any combination of those implants. In a TSA, that's good for patients with regular osteoarthritis and an intact rotator cuff. It's a polished metal ball attached to a stem that's pushed into the medullary cavity of the bone, and in most cases, the glenoid is replaced with a polyurethane dish. This is a reverse total shoulder, and that was approved fairly recently in 2004 by the FDA for use in the United States. The humeral head is replaced by a dish imitating the glenoid, and the glenoid is replaced by a semi-spherical ball imitating the humeral head. And this is reserved for the less active population because it's not as stable as a total shoulder, but that's okay because elderly don't have as high functioning use. In a cup arthroplasty, that's the most conservative means of treatment, and if possible, should be done first, and because this saves bone stock and it's easier to fix if complications occur. The rehabilitation postoperatively lasts around 16 weeks. In phase 1, you focus on patient education, healing of the wound, and then gentle range of motion exercises and constant sling use. In phase 2, you try to decrease the pain and inflammation and continue the range of motion exercises out of the sling. Phase 3 is full range of motion and trying to get the patient to be pain-free, increase function, and start strengthening the scapular stabilizers and rotator cuff muscles. Phase 4 is full function activities, long-term protection of the implant, and increasing the strength. This is a patient that had his right shoulder replaced. You can see that in the first two pictures that his right hand cannot go as far up his back, which is an indication that it's not as strong, there's not enough flexibility there, but functionally that's pretty good. Our hypothesis was that if some patients receive some form of total shoulder replacement, then their perception of their quality of life postoperatively should improve over time. The methodology: a survey was designed by an orthopedic fellow several years ago, and he got IRB approval, and the survey was administered during postoperative visits with Dr. Seitz, and that was continued by residents, fellows, interns, occupational therapy staff. The patients were asked to rate lifestyle activities such as bathing, eating, and sleeping on a -5 to +5 scale, with 0 being their preoperative state. So using this scale, patients were used as their own standard. They were also asked about satisfaction with the survey, if they benefited from it, and if they would have it again retrospectively, and many patients did the survey multiple times. The data was collected and then entered into Microsoft Excel 2003 and organized by procedure and etiology or disease type, and then broken down further by time frame. There were 142 people in the study, 77 females, 65 males, and 274 total surveys. The average age for all the patients was 69.282. This is the etiology distribution graph. The way the study was organized, the patients with multiple diseases would be put into multiple categories. This is why OA, which is osteoarthritis, and CTA contained is higher. Most elderly people have osteoarthritis to some degree, so they're put into this category. And then something similar with CTA contained. Most people don't notice it, but a lot of people have mild rotator cuff tears, so that's why they're put into that category. This is the procedural distribution graph. The vast majority of people had a standard total shoulder, while fairly equal amounts had a reverse total shoulder or a cup arthroplasty. This is a table looking at averages by total shoulder replacements, and you can see that very early on postoperatively numbers are very negative, but at the 2-year mark they're very positive. And then this is a very similar table, but it's just looking at the numbers by etiology, in this case osteoarthritis, and it's just showing the same thing. This chart looks at all the patients in this study, and it shows that every activity ends up being positive, but hobby and work are usually the lowest, while bathing, eating, and sleeping are the highest. And this also shows something similar, but it also shows that a standard total shoulder has higher ratings than the others. Overall, there was an increase in every category in the quality of life survey. It was apparent that the vast majority of people were satisfied with their surgery and agreed that they had benefited from it. This graph shows that there is a dramatic increase in activity ratings over time. The yellow and purple bars are generally pretty close, which are the 8-month to 2-year and the greater than 2-year bars, and that shows that there's a plateau at approximately 1 year of time. This is a very similar graph, but for a different procedure. This is for the reverse total shoulder. And also, right after the surgery, postoperatively, they have the highest activity ratings, but this graph isn't as reliable as the others because there weren't as many respondents in these categories. This is the same graph for cup arthroplasty, and you can see that hobby and work are very inconsistent. That's because there's not enough respondents in that category. This is all of the revisions over time, and this also shows that there's a steady increase in activity ratings. This graph is a breakdown of all revisions. There's TSA revision, RTSA revision, and cup revision, and it shows that the standard total shoulder implant has the highest ratings. This is all of the procedures, and this also shows that TSA has the highest ratings. This table shows that the TSA numbers were as high as 97% for the percent that feel that they have benefited from the procedure, but cup revision numbers were as low as 55% in the percent satisfied category. Overall, rheumatoid arthritis patients had the overall highest activity ratings compared to their preoperative conditions. Contained CTA had the lowest ratings overall for an etiology, but were still generally positive. All procedures and etiologies showed plateaus in improvement at approximately 1 year. And these are some of the patient testimonies. Most of them were very positive and praising the surgeon, Dr. Seitz, on his good job. And for the conclusions, the hypothesis that patient-perceived quality of life should improve after a total shoulder procedure was shown to be valid. Activity ratings, for example, had an average increase of positive 2.446 compared to the preoperative state of 0, and patients' progress reached the approximate end result at around a year. Patients that had a TSA were generally more content with their lives than those that had other replacements, and this reflects the more quantitative data that illustrates that standard replacements allow for more movement and more stability than other implant types. RTSA recipients were generally not as pleased, which reflects the existing algorithms that allot reverse shoulders to older and less active populations. However, this contradicts our data because the average age for RTSA recipients was 65.778 compared to the average age of all of the patients, which was 69.282. Conversely, rheumatoid arthritis patients had the highest rate of improvement and plateaued earlier than others, and this can be due to the notion that their pain, which is usually allocated throughout their whole body, has caused them to have a higher pain tolerance than others. So after they have the implant and their pain is gone, they realize how much better and pain-free they are. On these graphs, the blue and red represent the percent that believe that they benefited from the procedure or are satisfied with the procedure, and it's obvious that these numbers are overwhelmingly positive. This is one of the most important graphs. The blue represents the people that would have the procedure again retrospectively, and those numbers are very high. For recommendations, a similar study could be performed that looks at the same patients of a set sample size at regular intervals. And also, probably the main purpose of the study was to give data that could help further patient education and awareness regarding rehab procedures and show that things can be challenging in the beginning, but that the end result, which is usually around a year, is generally very rewarding and positive. I would like to thank my mentor, Dr. Seitz, Maureen and Mary, his secretaries, Dr. Yuji Umeda, who designed the survey, Ernest Michaud, my co-intern, Brian Nalitz, Nedra Starling, Rosalind Strickland, and the whole Office of Civic Education Initiatives for this opportunity.